So, a lot of people want to know about the new Society of Critical Care Medicine guidelines for sepsis and why they're getting away from the CIRS criteria. So, Doc, what do you think about it?
So the big problem with sepsis is recognition and realizing that a person has a septic event so that we can intervene quickly. And that almost always happens not just in the emergency room, but really in the field, in people's homes and on the ambulance. So the earlier tools that we use to detect sepsis, a lot of them required lab values and prognostics over time. Now we've really distilled it down to the QSOFA score, which is an easy to remember tool that can be done right in somebody's home or in a truck so you can recognize sepsis and start treatment early. And that's been a big purpose of the guideline change. So for a long time we used the CIRS criteria to define sepsis, but we're starting to get away from that because it wasn't sensitive enough. SOFA's actually been around for a long time. It's a sepsis-related organ failure assessment tool. It's mainly used in ICUs, and it's really complicated if you look it up. It uses lab values, bilirubin, creatinine, values that we're not getting, not in the ambulance, but not even in the ER right away. So what has been done with the new guidelines is they created the QSOFA score, the quick SOFA. So it has now just down to just 3 values. And those 3 values are patient with altered mental status, respiratory rate greater than 22 a minute, or systolic blood pressure under 100. It's that simple.
And what's really interesting about the quick SOFA score is it is now an objective standardized tool for all EMS systems to alert emergency departments to say, hey, this patient who we have good reason to suspect has an infection. We can either see it in a Foley catheter, we see evidence of it, we actually see an infected wound, we see evidence of pneumonia when you're listening to lung sounds, you have a fever and diminished breath sounds on the one side with congestion, productive cough. If they have a positive QSOFA score, or which is really, if you have got 1 positive finding on your quick SOFA, they really prefer 2, you've got a very high index of suspicion that this patient has sepsis. It's a very objective, standardized tool. What they've then gone on to say is anyone with a positive QSOFA score, and if they have an elevated lactate, if you can test that, or after fluid resuscitation, their blood pressure remains under 100, they're in septic shock. That is diagnostic. You can fairly accurately rely on that, and that's when EMS providers can start intervening and managing these patients. So you've got your sepsis alert to tell everyone, alert the emergency departments in a standardized fashion, and now you can then turn around and start treating. The most important treatment to start in the field is a complete 30 milliliters per kilogram fluid bolus. It's no longer just give them 2 liters, give them a liter, see what happens. You want to complete the entire 30 milliliters per kilogram. If after that they're still hypotensive, or if you can test lactate and lactate's greater than 2, you have septic shock. Those patients probably benefit from pre-hospital antibiotics.
So QSOFA is a brand new concept. It was just derived only a few months ago was the initial publication. So we are going to see this penetrate slowly into EMS systems. But it is going to happen because these are the not just national but really international guidelines for sepsis. Change takes time, and we all know that. But we anticipate seeing this written into protocols nationally, and it will trickle down. I think that EMS providers are going to see their new assessment tool for sepsis is going to be the QSOFA score. It's easy. It requires information that's readily available on the ambulance. And then, based on that, you're going to see your treatment algorithms focus heavily on IV fluid resuscitation and giving large amounts of fluids, transitioning to pressors as needed, and in some systems, antibiotics is something that we're starting to see in the field. Additionally is testing for lactate, and as we see more portable lactate meters, this is becoming more and more common. I think you're going to see that in their protocols too.
What's really important about transitioning to QSOFA as an EMS system is to do it just that as a system. We can't do it in a silo anymore. We have got to speak the same language as our emergency departments and as our hospitals. So if we want to adapt QSOFA into our pre-hospital algorithms, we need to sit down at the table with leadership from the emergency departments and the hospitals that we want to deliver patients to and make sure everyone is prepared to use QSOFA and SOFA scores within their system so that we don't turn to a nurse and say, hey, they've got a positive QSOFA score, this is what I'm doing, and they look at you like you have a square head because that's not the language they're using in their hospital. So this is going to be a true collaborative effort, but if we do that, I think we can see some really great improved outcomes in early aggressive sepsis care.
Yeah, our talk is focused heavily on how can you take these new guidelines and apply them into your care of patients tomorrow. Sepsis is a huge disease, not just in the United States, but the entire world, and it's something that the typical EMS provider will probably see a patient maybe even once a shift with sepsis. So in our talk, we're going to focus on identifying sepsis with the new tools of Q-SOFA and lactate, and then treating sepsis aggressively in the field and getting the treatment started as soon as possible. The studies that we have shown that the sooner you get treatment on board with fluids or antibiotics, mortality decreases by the hour. So it's really important that we push this diagnostics and care forward out into the field to get it to the patients that need it as soon as possible.
You want to be a patient advocate. If you're thinking sepsis, you've got evidence that a patient has sepsis, you want to go ahead and treat it. It's okay to be wrong. We would rather be wrong and have treated than be hesitant and find out later that this patient had septic shock and that now we're behind the 8 ball, because we have actually proven, and there's great evidence for it, as Sean was speaking of, sepsis is our next time-sensitive emergency. We need to treat sepsis management with the same sense of urgency as we treat STEMI, stroke, and trauma. It really completes the next step of the circle of time-sensitive emergencies we can make a difference on in pre-hospital care.